something that is for follow-up once they come into the US. So those are the Class A and the Class B screenings that are done. On arrival in the US, the CDC, on arrival in the US, the CDC, who basically oversaw the process of the overseas medical screening, notifies those receiving states about the findings on the medical screening so that they can be prepared, the public health officials there can be prepared to act according to respond accordingly and provide the necessary care. Also, an arrival in the US within 30 to 90 days, within a month, within 1 to 3 months of arrival in the United States, there's a domestic refugee health assessment. So that's the second screening, and essentially it's a follow-up with any Class A or Class B conditions. It's also conducted by physicians, but in various settings. It could be in a private clinic, in a hospital, community health center. It could be, in a local department of health, for instance. It's a collaboration. The states is coordinated and operated at the state level, but it's funded by the Federal Office of Refugee Resettlement. We partner with the states in this effort.
If I can add, just to remind again, it's part of the person is displaced from his or her country, and it has to go through all those processes, and as he or she goes through those processes, that adds up to maybe the mental issue, to the anguish, to maybe the hope things are going to happen, and then things don't happen at the pace, the speed that they expected. And all of this is now compiled in terms of both mental distress, which also now is going to affect them physically. So it was important to underline that all the host of mental and physical illnesses and illness will come with is going to impact them, and that's where the affordable care is going to help as well.
Absolutely. And another thing too is, as you can imagine, so we've been through a 6 to 8 month period, the screening process. It's not only the medical screening, there's security screening and all these other screenings. And at the end of it, you test positive for TB, and the treatment for TB could last 9 months. And so you have to complete that process and then join the line again, and those kinds of things. And if members of your family didn't test positive for TB and they got screened in and ended up being transferred, resettled, and you have to kind of wait. It's stressful for both sides, those who were able to come through and those who weren't able to, and have to wait for the period of treatment to come to completion. So after that initial refugee health assessment, this is the second screening. Well, this is the domestic screening. For the 8 months, and it's been alluded to already, for 8 months, the refugee health, medical costs, and other health-associated, the coverage of the care, medical care is covered through the Refugee Medical Assistance Program. So that lasts for an 8-month period. So, and the purpose really in that whole process, the purpose in that whole process, is to, the main goal is to help refugees access and utilize the US health system in a way that develops health sufficiency. That's really one of the stated goals. So the Affordable Care Act, essentially the full name is the Patient Protection and Affordable Care Act, signed into law March 23, 2010 by President Obama. The overarching principles that were driving the crafting of this law were to expand the coverage coverage to more people, particularly those who are vulnerable groups. So, the people who have serious chronic illness, children, low-income families, those who are low-income but maybe working, but working in low-income positions, so that 1 year you qualify for Medicaid, but the next year maybe you made a couple dollars more and you didn't qualify for Medicaid, and so you're in and out of coverage, and yet really your actual economic status hasn't changed very much, if anything at all. And so also to promote a preventive approach to healthcare versus the traditional curative approach to healthcare, whereby we wait for somebody, but we essentially wait for people to get sick, and then our whole system is designed to respond to that versus to prevent, which is better for people, but also more, it's actually cheaper to do that. But not only to provide more coverage, but to provide better quality coverage. Another, there were notorious discriminatory practices particularly through health insurance companies, and we'll talk about it a little bit more, that's part of what the ACA seeks to end. Then the other issue is one of continuous quality improvement in healthcare systems. And then lastly, to this balancing act of increasing affordability, but also reducing costs. It's a balancing act, but there's hundreds of millions of dollars of documented in medical waste, actually, the way that medical care is provided, and there's steps being taken to reduce costs in that way without necessarily, so in other words, you're not starving the system, but you're cutting back on waste and fraud and things like that. So, we'll just pull out a few, I'm sorry, there we go. Just pull out a few of these key provisions and kind of discuss them that way. So, insurance security. So if you think of food security, you think of housing security, you think of national security. Insurance security essentially is referring to people knowing that they can access affordable health insurance and they can keep it. So just by way of background, so we're in a situation where, I'm sorry, this did not change. Sorry, there we go. So we had millions of uninsured or underinsured people. It was a very unsustainable system. So I think everyone here pretty much understands how in the US, over 80% of people who have health insurance have it through an employment-based insurance model. So as part of the benefits that you receive from your employer, you get health coverage, so that essentially they contribute towards your medical costs if and when you have medical costs, so that that's one, they reduce the amount of money that you have to pay to receive healthcare. Now, in the 80s and 90s, particularly starting off in the 80s and 90s, there was a steep increase in the cost of providing healthcare. There was also a steep increase in the cost of providing health insurance. At the same time, there was a steady decrease in the number of people who were receiving health coverage, who were covered by insurance. At the same time, if you looked at the quality of care, in other words, the outcome of those who are actually entering into, who are interfacing with healthcare and getting medical care, there was either mostly a stagnation in the quality of care, or the overall quality of care. There was some improvements. There's also a lot of decline, but overall it was stagnant. But if you consider the costs, how much more it was costing, you'd at least hope that you're getting improved quality of care as a result of those improved costs. We were not getting that. So one of the things that the Affordable Care Act does, and this will particularly kick in 2014, is the expansion of Medicaid to everybody under the age of 65 whose income is up to the level of 133% of the federal poverty level, and we'll look at that a little bit going forward. And you don't even have to have dependent children, which is one of the criteria at present. So you might have adult children, or you might not have children at all, but you'd still qualify. And this applies to refugees also. Another method of guaranteeing insurance security is the establishment of health insurance exchanges. So there's been a lot about that, a lot of information about that in the media, and I'm sure most of you know what I will give, but a simple description of that would be, consider it like a shopping mall, not a department store like a Macy's or whatever, where there's a